Good morning and welcome everybody to Global Healthcast, brought to you by Global Health Press. In this broadcast series, we talk once a week about all types of globally relevant infectious diseases. I am Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning, Melvin.
Good morning, Professor Schmidt, and good afternoon or good evening to everyone, depending on where you're from, where you're listening or watching this podcast.
What we're talking about today is COVID-19 update, as always. We start a little bit speaking about good medical language. Melvin will present you public health emergencies of international concern. And I will present you again language errors in the media. And as always, we start with COVID-19 update. Where are we, Melvin?
Yes, as usual, this is from the WHO COVID-19 situation report released a few days ago. As you can see here, after an increasing trend over the past 5 weeks globally, the number of weekly cases last week remained stable compared to the previous week, with just around 6.3 million new cases. And the number of new weekly deaths also was similar to the previous one, with around 11,000 fatalities. And remember, 3 or 4 weeks ago, Professor, we said, what will happen with the increased number of cases? Will we also see increased number of deaths? And during that time, we said we don't know if more cases will translate to really more deaths, right? And it has been 4 weeks now, and I guess now we know the answer to that.
That is good to hear, and it's also reassuring. I would use this data to as an indication that vaccines are working. You don't see an increase in number of deaths while the case rate is going up a little bit, but there was no change. Or do you think the mortality may come a little bit later only? What's your perception here on vaccine effect? Can you read something out of this?
Well, it's what we've been saying for the past 3 4 weeks, right? To see what happens 3 or 4 weeks after, and it seems like we're not seeing an increase in deaths. So I guess we can assume that the vaccines are really doing what they're supposed to do, which is to prevent serious consequences of COVID.
Yeah. And that's the main issue. You don't want to die. You don't want to be in intensive care. That is the only thing you can do. We call it control of the disease. We cannot eliminate the organism, but we can control the disease. And I guess that's what vaccines seem to be doing now in most countries of the world right now. Great, Melvin. And
Yep.
here is your next slide.
Yes, and this one just shows on top the number of samples submitted and the different variants and subvariants with the different colors. And the one below shows the percentages of the SARS-CoV-2 sequences over time, also showing the variants and the subvariants. As you can see, early in April, it was mostly BA.2 and the subvariants of BA.2. And then mid-June, you will see that BA.4 and BA.5 started to dominate. And this is, of course, important from a scientific point of view. But, the constant focus on these new variants and antibodies is frankly confusing a lot of people. Every time they hear that the new subvariants are more immune evasive, the message they get is that vaccines do not work anymore. And this is absolutely not true. The vaccines are still doing what they're supposed to do. And this is already 2 years after they were developed, right? And if we go to the next slide, this is from Professor Stanley Plotkin, actually. In his recent lecture, he emphasized that the protective mechanism induced by vaccination is not just antibodies. As you see here, you have serum antibodies, mucosal antibodies, CD4 T cells, CD8 T cells, and more. And Professor Schmidt already discussed this in our first Global Health Cast, but I just want to emphasize again because it's really the physicians and scientists who are always on mainstream media being interviewed, and those who are active on social media, not all of them, but many, who are always promoting this narrative that because the variants can escape antibodies, we are no longer protected. And I think this is really Not good, because they are undermining the message that vaccines save lives and are still saving lives. And as long as you are vaccinated, you're boosted, your chronic medical conditions are controlled, your risk of getting severe COVID is low.
Melvin, the message is the immune system is more than just antibodies. And lack of antibodies does not mean you're not protected. And I think there are many other reasons and many other mechanisms that result in protection. And just determining the amount of antibodies in your blood is stupid and a waste of money and a waste of your time, by the way, as well. So it doesn't mean anything, right? I mean,
Exactly.
you may feel better, but the purpose of medicine is not to make you feel better, but to do the right thing for your life and health. So
Yep,
measuring antibodies, except for diagnostic purposes or for clinical studies, it doesn't make much sense.
I agree.
Yeah, very good. I had a student, and after a long discussion on some immunology topic, they were asked to have a little exam, and they were supposed to write a little bit on the topic of, I don't remember what it was. And on the piece of paper that all students received, it said, write 80 to 100 words. So this is exactly what the student did. And this is what I want to use as a start, that after good clinical practice, good manufacturing practice, good laboratory practice, and all these good whatever type of practices, we should start an initiative on good medical language, or GML. I think it is prerequisite for good science and understanding. And if your wording is not correct, you will not be understood. And I think, as I will show you later, this is a main issue now with COVID. It's a lack of right wording and understanding that leads to misinterpretations and wrong ideas about COVID and all types of infectious diseases. I have some examples. This is from a protocol, and it said this study was done to evaluate the efficacy of influenza vaccine in reducing the incidence in patients with all-cause pneumonia. All-cause pneumonia means everything that causes pneumonia. And I've listed here just a couple of organisms. I think there must be dozens of organisms, including plague, that the plague bacillus that may cause pneumonia. And this is just the one that came to my mind last night. So you cannot have all-cause pneumonia. Anybody, I mean, this never happened ever. Nobody ever will have all-cause pneumonia. The right wording would be pneumonia of any cause. Well, you may say, look, it is understood, right? But all-cause pneumonia is simply a wrong concept, and people should avoid using wrong wording, and it is any cause and not all cause. This is more clear, and this is not, I'm not a native speaker type of, well, but it is understood among native speakers what it means. This is a factually wrong wording. Adolescents are a relevant reservoir of the meningococcus, and in this age group, meningococcal disease causes the highest mortality. Now, meningococcal disease has a frequency of 1 per 250,000, roughly, in the Western world, outside of an outbreak. So 1 out of 250,000. And mortality is all deaths in the population, in the whole population, including car accidents, cancer, whatever, everything included. So no way that a disease with a frequency of 1 per 250,000 and a case fatality rate of not even 10% would be the cause of the highest mortality in this age group. The right wording is certainly case fatality, and it's not mortality. It is the number of deaths among all those who had the disease, and not the number of deaths in the respective population. And by the way, there is not one meningococcal disease. It certainly should be meningococcal diseases. There is septicemia, there is meningitis, there is pneumonia. There are all types of meningococcal diseases, and there is not one disease. The case fatality and mortality, this is really right and wrong. But disease and diseases, you may debate as a native speaker. You may say, but this is what I meant, and this is the way we use the language. It is wrong anyway. If you're German, in Germany, it clearly would be wrong. Meningococcal disease versus disease is something different. This is something I like very much. You find it wrong very often in textbook. Ticks are the carriers of many severe diseases. Here I have listed all tick-borne diseases like Lyme disease, tick-borne encephalitis, babiosis. You can read them all here. And this is the cause of these diseases, which are bacteria, viruses, or even parasites. Now, we have to distinguish between disease and the cause of the disease, the microbe causing the disease. So if you go back to the sentence, carrier of diseases, ticks don't carry diseases, they carry microbes. And this is very simple, right? Ticks are the carriers of many microorganisms, and then you can say which may cause severe diseases. Now, this is another one I like very much. She developed Lyme disease after a tick bite. We will never be able in our lives, and whatever amount of money and efforts we would be able to take to change the word tick bite. The thing to remember, though, will be or is ticks cannot bite because they have no teeth. Now, what you see here is the mouth of a of a tick, and this is sort of their feet, these paddles here. And instead of teeth, they have these chainsaw-like organism, yeah, whatever it is, structure, and it looks like a chainsaw, right? It is not a sting. They don't sting you, and they don't bite. Whatever they do, I have no idea how you should best call it, as I'm not a native speaker. They don't chainsaw you, right? They twiddle this instrument into your skin, and this is how it looks like. And as this is a mouth where the chainsaw instrument comes from, I guess you would be able to call it ticks give unfriendly kisses on your skin. I'm not sure this may be funny, but and closer to the truth, instead of tick bite, we will not be able to change tick bite ever in our lives. So we have to use the term. I'm not a native speaker, but if you have other such examples, please send them to me. If you have any comments on what I said or wrote on my slides, please tell me. And we want to sum this up a little bit and we'll publish it at some point. I'm very eager to get to know your bad language examples, medical language examples. Melvin, your topic is the next, public health emergencies.
Yes, so we've seen this being used in the mainstream media and social media in the past few days because, just recently, the WHO declared monkeypox as a public health emergency of international concern, right? And you can read here the definition on the slide, but the definition implies that an event can be called a public health emergency of international concern. Some people call it PHEIC, some people call it PHEIC. I guess if you're a German, you call it PHEIC, right? But okay, so let's just say it's PHEIC, or I'm not even sure. Okay, fake. So the definition implies that the situation is serious, sudden, unusual, or unexpected. And is monkeypox serious, sudden, unusual, or unexpected? And I would say yes, because at the moment there are over 15,000 cases in 70 countries all over the world in which monkeypox is not considered endemic, but they have now reported outbreaks of the viral disease. In previous outbreaks, the disease mainly occurred in West and Central Africa and only occasionally spread elsewhere. And most of these cases in the past can still be traced to West and Central Africa. The second characteristic is that it carries implications for public health beyond an affected country's borders. And because beyond the 70 countries, we want to make sure that the outbreak does not spread further. And also in these 70 countries, we want to make sure that the outbreak is controlled. So I think, yes, monkeypox really now sort of should be considered a PHEIC because of this. And then the last characteristic is that it may require immediate international action. And for me, declaring a PHEIC is because it is the highest level of alert that the WHO can declare, right? It is meant to send a powerful signal to countries of the need for current and urgent action to combat the spread of this disease and to mobilize resources to help low and middle income countries in the effort and to fund research and development on needed treatments, vaccines, and diagnostic. And it also obligates countries to share information with the WHO. And so I think if we want to reach a point where we can recognize these emerging infectious diseases before they start to take off, we need a system of surveillance, laboratory testing, and interconnectivity that is just missing at the moment. I think if we go to the next slide, so this is the definition basically that I mentioned, the three characteristics. And in the next slide, you will see all the different public health emergencies of international concern that were declared since 2009. Um, so, of course, you see here COVID just recently. We had Ebola in 2019, Zika in 2016, Ebola again in 2014, polio in 2014, and 2009 was the H1N1 swine flu, which started in Mexico and spread across the world. What I just wanted to say here that so far, before monkeypox, only six have been declared, with the first, of course, being this H1N1 flu outbreak, which fizzled out quickly despite causing 280,000 deaths globally. During the H1N1 outbreak, when WHO declared this, um, they they rescinded both in August, as the outbreak was judged to have transitioned to behave like a seasonal flu. And during that time, WHO was criticized afterwards for prematurely declaring a public health emergency of international concern and overreacting. And this might have impacted the delay in declaring the Ebola outbreak in West Africa as a public health emergency of international concern in 2014. And we've seen this play in the COVID situation as well, right? So early in January in 2020, when it was declared a public health emergency of national concern, some people were saying that it was too early to declare that. Some people were saying that it should have been declared earlier. And then it was declared a pandemic in March. And also during that time, people were saying that it should have been declared earlier. And some people were saying that it should not have been declared. So now we're also seeing the same thing for monkeypox. There are people saying that this should not have been declared a pandemic of public health emergency of international concern. But I think this is a good move for WHO, because declaring something as a public health emergency of international concern has implications for coordination of the international community and for putting in funds for research and of course, for surveillance. So I think this was a good move for WHO.
Melvin, that is very interesting. And I remember the 2009 H1N1 swine flu pandemic really well. It started in Mexico, and for whatever reason, there was a high case fatality rate in Mexico.
Mm-hmm.
And the question is always, how will this develop? And it is very difficult to predict the future. How can you predict the future of COVID, of H1N1, of whatever type of influenza vaccine, of RSV? We don't know. And they are, whatever you do is wrong. It is a funny situation. If you're too late, you're blamed for being too late. And if you're early on and if you're very careful, then they tell you overreacted. So I think from a public health point of view, I would be happy to take a few that would not have been necessary PHEICs instead of having one that is disastrous and it never comes or comes too late. So I'm not sure how you see this, but this is a public health, whatever you do is wrong situation.
Yeah, and I think this is really tricky for the WHO as well, right? Because as you said, it's either too early or too late. But I think what's more important really is for the WHO and the rest of the world to have the surveillance systems and to really follow the events, because we've identified that this is an issue at the moment, right? But then what's next? We
Yeah.
should really look at the number of cases, because I'm sure the 15,000 cases that we are mentioning is not just 15,000. I'm sure there are other cases that we have not identified, right?
Yeah. Yeah. Very interesting discussion. So outbreaks will continue to affect us. I just looked at 2009 to 14 is like 5 years. and then the same year Ebola, and then it took like 2 years for Zika, and then 3 years for Ebola, 1 year for COVID. It's getting more rapid now, right? These
Yes.
peaks are with us, and that certainly has to do with the ever increasing world population. The more humans there are, the more infectious diseases there will be. That's it. And the spreading is easier with flying and cruise ships and all these things. So exposure is more, so infectious diseases are more. Very, very simple. Melvin,
Yep.
thank you. That was great. I have a few more on good medical language, and it is focusing on examples from the media. And I don't want to blame one medium particularly, but let's start with the 2020 situation on COVID, when in German public television they said Company X had a vaccine against COVID. And that was everybody believing there is a vaccine. We don't need to worry. The right word would have been vaccine candidate. There was no licensed product. There was a vaccine in early stages of development. I think even not in a phase one clinical trial. So they had an idea how to make a vaccine, but in no way they had a vaccine. So this was misinformation early on in 2020. Another item as a pediatrician, what I like very much to hear, small children should not be vaccinated or cannot be vaccinated against COVID. Look, small is size, and the size doesn't matter when it comes to vaccination. It is age, right? And when it comes to age, as a pediatrician, we distinguish between newborns, infants, toddlers, kindergarten children, and so on. But small children, taking the size for age is simply wrong. And even a journalist should know the difference between small and young or old. Immunity and protection we covered again today with Melvin. There is immunity. You measure antibody responses, you measure CD4 cells, CD8 cells, whatever you measure. And then there is protection. You measure how well a person after exposure is protected from coming down with a disease. So there are two different items, but they mix this up all the time. And the worst is the term seroprotection. If you have antibodies against a certain disease, they tell you, or the idea is you may be protected, which is wrong. I have great antibodies against diphtheria. I had been in the German army decades ago, and I get tons of tetanus diphtheria shots in my life. So I have great diphtheria antibodies. But Melvin is a bad guy, and if he takes diphtheria toxin and injects it into my blood, I will survive. But with increasing amounts of toxin, I will die at some point. It's a question of dosing. So even if I have antibodies, they don't help me. So some, and actually more than 90% of all antibodies are regulatory antibodies anyway, and they are not killing whatever the toxin or the microbe. So the term seroprotection is a licensing term that has nothing to do with real protection. Efficacy and effectiveness, we will cover at another time. Herd immunity means you vaccinate someone with oral polio, a live vaccine. The vaccine is shed with the stool of the infant or the person, and then it is brought into the body of someone else by not washing hands in the end, right? You swallow the stool of someone else, and then you get immunity. You really develop antibodies against the polio vaccine from being in close contact with the stool of the person who had been vaccinated. This is herd immunity, and polio is the example for this. Herd protection means you have a high rate of vaccination in against a respective disease. And then even if you only vaccinate 95%, the disease becomes so rare that it cannot spread. The organism cannot spread, and that is why you're protected. So herd immunity and herd protection is two different things. And COVID vaccines never ever can induce herd protection. They only herd immunity. They only can provide herd protection. I don't want to go into licensure versus recommendation, sensitivity and specificity versus predictive value. Disease versus syndrome is one of my favorites, but it takes too long here. I just want to make sure that the right terms are used, and the media have it wrong all the time because journalists don't understand the difference between the words. And I guess in the end, I have what we started with, microorganisms is different from diseases. So many microorganisms may be found in ticks, but ticks don't carry diseases, they carry microorganisms. Melvin, any ideas from your point? Any comments on good
Well,
medical language?
my favorite is actually nowadays is infection and disease because
Ah,
people think that once you're infected with something, you will have the disease immediately, which again goes back to your own immune system,
yeah,
whether you had immunity in the past, whether you're vaccinated, and all these things, right? With COVID, for example, right? So you're infected with SARS-CoV-2, okay, you're infected, but it doesn't mean that you will have the disease
yeah,
immediately, right? And people
yeah.
are always confusing this, and that's the reason why, because of all these BA.4, BA.5, many people are infected, and people are scared because they will have the disease or will die from COVID. And really, again, we should go back to our messaging that um, as long as you're vaccinated, you're boosted, your chronic medical conditions are controlled, the risk of severe COVID or serious consequences of COVID is actually quite low at the moment.
Great points, Melvin. Thank you. And infection and infectious disease is two different things. Thanks for clarifying that as well. I put it on my list. And anybody else who has an idea on, any examples, please send them to us. And that was our broadcast today. We talked about COVID-19 update. Cases are plateauing. The death rate is still roughly the same. I gave you some examples on good and bad medical language and why it is important to use good medical language. Melvin updated you on public health emergency of international concern, PHEICs or PHEICs. And the important issue is not to be too late. And I would prefer to be a little bit early and a little bit maybe sometimes not needed than being too late and there is a disaster. But that is, I guess, some political decision then in the end. And finally, I gave you some examples for language areas in the media. So, Melvin, my last question is how many COVID vaccine doses should I take?
Well, for this question, it really depends on several factors, right? Your age, recommendation for your age, and I guess it's always the two first doses of the primary vaccination series, and then the booster, which depends on many countries. Some countries would say one booster for basically everyone, and then another booster if you're over 60 or you have chronic medical conditions or taking immunosuppressive medication. So I guess it depends on the person.
Well, that was a very scientific and very public health oriented answer. I have a very simple answer that you may bear in mind. If you're clever, you take them all, right? That is the simple question, the simple answer. This was our Global Healthcast on July 26, 2022. Please like, share, and leave your comments below. Thanks for joining us today. I am Joe Schmitt.
And I'm Melvin Sanicas. Thank you very much. Stay safe, everyone.